Pial synangiosis requires a careful operating room setup. This includes a standard craniotomy tray, drill, microdissection instruments, a Doppler, and EEG setup. It is important to place the EEG leads in such a way that they do not preclude access to the parietal branch of the superficial temporal artery. Here we can map out the course of the STA using the Doppler, and the child is positioned neutral. The incision is started at the distal end near the vertex under the microscope, using a Jake's forceps and 15 blade to find the branch of the superficial temporal artery to be used. The assistant usually cuts over the knife, and then as one progresses, the side branches are carefully cauterized and then divided, using either micro scissors or, in this case, the Colorado tip needle on the boveolectric cautery. It is important to leave a cuff of tissue around the artery, which facilitates ingrowth of new vessels once transplanted. Following this, the vessel is lifted off the temporalis, a plane is created between the Galea and temporalis and retracted as seen here, and then the temporalis muscle is divided into quadrants with one axis along the axis of the artery and the second perpendicular to it, with the muscles lifted up, and then a craniotomy turned with burr holes at the base and the apex of the artery and the footplate carefully used, with the care being made by the assistant to protect the artery at all times, using instruments to prevent the drill from injuring the artery. Once the craniotomy is turned, all bone dust is removed with irrigation. The bone flap is carefully removed, taking sure not to injure the artery, and then the dura is opened in a pie-shaped fashion using a 15-blade dental instrument and scissors. It is important to note in the preoperative imaging whether or not any transdural collaterals exist arising from the middle meningeal or dural branches, such that these are not interrupted. If present, they should be spared if possible, using scissors or a blade to cut around the vessel and preserve the middle meningeal. It is also important to know that there are sometimes tiny vessels arising from the brain that go to the dura, and these can be protected many times with careful dissection using the blade as seen here, or the micro scissors or Metzenbaums as needed. Once the dura leaves are flapped back and tacked back with neurons, the arachnoid needs to be opened, usually over the vessels as seen here. The microscope is brought back in, and then arachnoid is opened widely. When the arachnoid has been opened, the vessel is prepared for synangiosis and a 10-0 nylon is used. The assistant will hold the vessel out of play, while the first stitch is usually placed just under the pia so as not to cause any bleeding, and then the second stitch, once placed through the pia, is elevated out, taking control of the needle during the entire time, with the second throw of the stitch being placed through the soft tissue on the undersurface of the donor artery. This is done, and then the needle is cut, and with the appropriate length of suture remained, the suture can be tied, usually with 4 throws, holding the vessel against the surface of the brain. This helps the vessel to grow in without losing any connection to the brain, and also facilitates communication of growth factors from the brain to the donor vessel. Usually 4 or so stitches are placed, inspected, and then the dural flaps are laid back on without suturing, followed by a piece of saline-soaked gel foam. The bone flap is replaced with appropriate care not to injure the vessel, and then the temporalis is closed in the horizontal plane but not the vertical plane so as not to compress the vessel. Once concluded, the entire site is closed using 4-0 vicryls or 3-0 vicryls depending on the age of the child, and then a dissolvable skin suture. The child is then maintained in the ICU, and with time additional collaterals will grow in, hopefully protecting the child against future stroke.